Hello everybody, my name is Mohamed Sadiq and today we'll be talking about AV nodal related bradycardias. So bradycardia is any rhythm with a ventricular rate of less than 60 beats per minute, meaning a pulse of less than 60 beats per minute. Now, some population studies and guidelines will use less than 50 beats per minute as the cutoff. But classically in medical textbooks, 60 beats per minute is what's used. When somebody has a low pulse of less than 50 to 60 beats per minute, they may start developing symptoms. Now, whether they develop symptoms or not, it will depend on their general health, other comorbidities, and the actual heart rate. So somebody with a heart rate of 15 to 20 beats per minute is more likely to be symptomatic than somebody with a heart rate of 45 to 50 beats per minute. These symptoms include fatigue, shortness of breath, lightheadedness, or what we call presyncope, loss of consciousness, or what we call syncope, or potentially death. When we talk about bradycardia, there are two structures in the heart where bradycardia can be localized to as being the cause. The first is the sinoatrial node, the normal pacemaker of the heart where depolarization usually begins. Problems with the sinoatrial node can either be due to abnormal impulse formation or abnormal impulse conduction. The other structure is the AV node, which sits between the atria and the ventricles and is usually the only path of depolarization from the top chambers to the bottom chambers. Here at the AV node, the problem is usually an issue of impulse propagation. Today we'll be talking about AV nodal related bradycardias. So here's the AV node related bradycardias. First degree AV block, second degree AV block, which is split into type 1 and type 2, and third degree AV block. In first degree AV block, all P waves are conducted. In second degree AV block, some P waves are conducted, and in third degree AV block, no P waves are conducted. Let's talk about first degree AV block first. First degree AV block refers to when the PR interval, which is the beginning of the P to the beginning of the QRS, is more than 200 milliseconds, so more than one large square. Here's an example where you see that this interval from the beginning of the P wave to the beginning of the QRS is greater than one large square, so greater than 200 milliseconds, and so this patient has a long PR interval, so first degree AV block. Here's an example of first degree AV block, and what I would do is I would find the beginning of a QRS or beginning of a P wave that land on the dark line or the beginning of a large square and use that to eyeball whether the PR interval is greater than one large square. And here you see that it definitely is. Now, it's very important to note that even though we call it first degree AV block, every sinus P wave is followed by a QRS complex, and every QRS complex is preceded by a sinus P wave. So there's actually no block. There's no block between the P wave and the QRS complexes. And if the P wave rate is 80 beats per minute, then the QRS rate will also be 80 beats per minute because for every P wave, there's a QRS complex. So essentially, first degree AV block is not a cause of bradycardia, and it's actually not block at all. It's kind of a misnomer, and instead of using first degree AV block, we should really be using a prolonged PR interval or prolonged AV conduction, prolonged atrioventricular conduction. So even though we classify first degree AV block as a type of AV block, it's not. And it simply is a way to describe prolonged AV conduction, or a long PR interval. And it's actually not a cause of bradycardia. Here's another example of a longer PR interval. Again, you see that the PR is very long, however, conduction is still 1-to-1. And here you have an example of a very long PR interval, where it's almost two large squares. The PR interval can get so long sometimes that the P wave lands in the preceding QRS complex. Here you can see the P waves, which are sharp deflections within the T wave. One hint that there is a P wave here within the T wave is the fact that there's a high frequency deflection within the T wave. The T wave is made up of repolarization, which is usually low frequency. When you see a high frequency deflection within the T wave, consider that there's a P wave buried in there. And here it's very clear in lead V1 that there is a high frequency deflection, and if you follow it down the leads, you'll see that there's actually a P wave buried in the QRS to T segment. Here the PR interval from the P wave to the QRS is very long, almost 2.5 to 3 large squares, but as you can see, there's still one P wave for every QRS complex, and it doesn't cause bradycardia, and there's no block. Every P wave still conducts to every QRS complex. Now, second degree AV block is split into type 1 and type 2. Type 1 is progressive PR prolongation before the block, so the PR interval prolongs and prolongs and prolongs until there's a block. Usually, type 1 second degree AV block is at the level of the AV node. And the reason it's important to recognize it is because it's not usually progressive. It carries a benign prognosis and does not usually need to be treated. Another name for type 1 second-degree AV block is AV Wenckebach, named after Dr. Wenckebach, who originally described this phenomenon. Here's an example of AV Wenckebach that conducts in a 3-to-2 fashion. There's 3 P waves for every 2 QRSs. Here you see that there's a P wave in the beginning that does not conduct to a QRS. This is followed by a P wave with a short PR interval that conducts to the QRS. There's another P wave with a longer PR interval. And then there's the third P wave, again blocks and does not conduct to a QRS. The cycle repeats, P wave with a short PR interval, P wave with a longer PR interval, P wave that blocks. So this sequence of P wave short PR interval, P wave longer PR interval, and P wave that blocks and does not conduct to the QRS gives you a pattern of 3-to-2 AV Wenckebach, 3 P waves for every 2 QRS complex. And we know that it's type 1 second degree because the PR interval is getting longer and longer before the block. Here's an example of 5-to-4 or 6-to-5 AV Wenckebach. Here you see a P wave with a short PR interval, followed by a P wave with a longer PR interval, another P wave with a longer PR interval, a fourth P wave with a longer PR interval, and finally a P wave that blocks and does not conduct. You can see that the PR interval is getting longer and longer and longer before it finally blocks, and there's a P wave without a QRS. So there's more P's than QRS complexes. Some of them conduct, and so this is second degree AV block, and because the PR interval is getting longer and longer, it's type 1 second degree AV block. It's important to recognize that when you have second degree type 1 AV block or AV Wenckebach, there is group beating of the QRS complexes. And you see that the QRS complexes are in groups which are separated by pauses. This is because every P wave conducts until one doesn't, and you get these groups of QRS complexes. This pattern of group beating is highly suggestive of AV Wenckebach. Here's another example of AV Wenckebach. You see a P wave with a long PR interval, P wave with a longer PR interval, P wave with a longer PR interval, and then this P wave is actually buried within the T wave. The reason we can decipher that there's a P wave there is that the P wave intervals should stay regular. And if we keep mapping the P waves as to where they should land, there should be another P wave here within the T wave. Now you can see that this T wave is slightly more peaked than prior T waves, meaning that there's likely a P wave inside it, making it a little bit more peaked. This particular P wave does not conduct and is blocked. The next P wave comes on time at the same expected interval and conducts with a shorter PR interval compared to the other P waves. And the cycle continues until you get a P wave with a long PR interval, and the final P wave blocks again, and the cycle resets. And here you see the pattern of group beating. One important thing to also recognize, sometimes it's hard to see the PR interval prolonging if you compare subsequent beats. So if you look at one beat and then you look at the beat after it and the beat after it, and you're just comparing those two next to each other, it's hard to see the subtle changes in PR interval. It may be prolonging a little bit, but it's hard to measure. What's easier is to measure the first PR interval and compare it to the last PR interval. So in other words, if you look at the PR interval before the blocked beat and you compare it to the PR interval after the blocked beat, you see that the PR interval before the block beat is quite long, and the PR interval after the block beat is much shorter, and that's visually easier to compare and easier to diagnose. Here's a last example where the PR prolongation is extremely subtle, and it's very hard to see the beat-to-beat PR prolongation. Here you see the P waves marching through at a standard rate, and you see that this P wave here blocks. So how do we know that this is a Wenckebach phenomenon? Well, if we compare the PR interval before this block to the PR interval after this block, you see that they are quite different. However, if you were to compare two PR intervals in the beginning of this ECG strip or two PR intervals in the end of this strip, you'll find that it's very hard to see the subtle prolongation. But if you compare the one before the block and the one after the block, it's much easier. Now, looking at second degree type 2 AV block, in this case, again, some of the P waves conduct and some don't, but there is no prolongation of the PR interval before the block. Type 2 block usually occurs below the level of the AV node, usually at the His-Purgatory system below the AV node. And it's important to recognize it because it can progress to third degree AV block or more advanced AV block. And thus, if you see type 2 AV block, because it is progressive and it could get worse, there is indication for treatment, mainly inserting a pacemaker. Here's an example of second-degree type 2 AV block. This is sometimes called Mobitz II AV block. Here you see the P waves marching through, and the PR intervals are very constant until you drop a P wave. So there's no warning. There's no prolongation of the PR intervals prior to the blocked P wave. And you see a constant PR interval until one P wave is not followed by QRS, and it's a sudden block. And that tells you that this is second-degree type 2 AV block, which is a worrisome finding. And if you compare the PR interval and the beat after the block to the beat before the block, they're exactly the same. There is no prolongation of the PR interval. This is another example from a strip. Again, you see that suddenly there's a P wave without a QRS complex following it, and there was no prolongation of the PR interval before this happening. So this is second-degree type 2 AV block. Now, one tricky diagnosis to make is if you have 2-to-1 AV block, so 2 P waves for every QRS. In this case, as in this example, you see the P waves marching through, but you see that every second P wave conducts to a QRS, whereas every second P wave blocks and does not conduct to a QRS. Well, which one is it? Is it type 1 or type 2? The answer is it's hard to tell, because you need 2 P waves to conduct in a row to tell whether it's type 1 or type 2. Because you need to see the PR prolong or not prolong in 2 consecutive beats to make a distinction as to whether this is type 1 or type 2. If every second P wave is blocking down to the QRS complex, then you can't tell if there's prolongation of the PR or not, and you can't classify it as type 1 or type 2. Well, what are different hints? One hint is that if the QRS complex is wide, it's more likely to be type 2. This is because if the QRS complex is wide, the diseased part of the conduction system is likely below the AV node. And if the QRS complex is narrow, it's more likely to be type 1. However, these rules are helpful but not conclusive. One simple strategy to do is try to get the patient's heart rate up. So either have them exercise in bed or move around, and by getting their heart rate up, you increase the sinus rate. And by increasing the sinus rate, you hope that 2 P waves will conduct in a row. And if 2 P waves conduct in a row, that transition point is where you can decide if this is type 1 or type 2. Here's an example where we can see the transition point. There's the P waves, and on the left side of the screen, you see that there is truly PR prolongation. The PR prolongs before there's a P wave that doesn't conduct. And on the right side of the screen, you see 2-to-1 AV block. So if we just saw the right side of the screen, we wouldn't know whether this is type 1 or type 2. But because we have the information from the left side, we know that there is PR prolongation, and so this must be second-degree type 1 AV block or AV Wenckebach. Now, 2-to-1 heart block can be tricky to recognize. And in this particular example, if we simply look at leads 1 and lead 2, we may think that this is sinus bradycardia, and bradycardia due to a problem in the sinus node. However, lead V1 is very useful to see hidden P waves. And if we look at lead V1, we see that it's actually not sinus bradycardia. The sinus rate is normal, but every second P wave does not conduct to a QRS. So this is actually 2-to-1 AV block, and so it's second-degree AV block. I'm unsure if this one is type 1 or type 2. It's likely type 1 because the QRS is narrow, but in order to be conclusive, we'd likely have to increase the sinus rate of the patient by having them exercise or move around in bed, and then we'd be able to tell if this is type 1 or type 2. The final AV node-related bradycardia is third-degree AV block, which is also called complete heart block. In this particular case, you see the P waves marching through the rhythm strip and see the QRSs marching through at their own rate. The P waves are depolarizing at their own rate, and the ventricles are depolarizing at their own slower rate. The P waves are regular, and the ventricles are regular at a slower rate. There is no connection or communication between the top chambers, the atria, and the bottom chamber, the ventricles. The connection is completely severed, and that's why we call this complete heart block. Here's another example where you see the P waves marching at their own rate. If you track the P wave intervals, you'll find that some P waves are hidden within the T wave. And you see that the QRS complexes are also marching at their own rate. The P wave intervals are regular, the QRS complexes are regular, they're not related to each other, and so this is an example of complete heart block where there's no relationship between the P wave and the QRSs. And it's important to note here that the QRS complexes here are usually bradycardic. and they're usually wide, because what we see when there's a block at the level of the AV node or just below the AV node, cells of the His-Purkinje system below the AV node or ventricular muscle tissue must take over the job of leading depolarization of the ventricles. If nothing takes over, then the person would drop dead because there's no rhythm in the ventricles and there's no heartbeat. These cells in the His-Purkinje system below the AV node or the cells in the ventricular myocardium depolarize at a slower rate than sinus node cells, atrial cells, or AV nodal cells. And so these escape rhythms from the His-Purkinje system or from the ventricles is slower. And usually the patient will present to hospital with a very slow heart rate as symptoms of either presyncope or syncope. And because this escape rhythm is originating from the His-Purkinje system below the AV node, so either the left bundle or the right bundle system, or from ventricular myocardium, and is not following the normal conduction pattern through the AV node, you're going to get a wide QRS. So these ventricular escape rhythms are usually wide, as in these examples that we showed. So in summary, there are 3 types of AV blocks. First degree AV block, all the P waves are conducted. It is not a cause of bradycardia and should likely be called prolonged AV conduction instead of AV block. Second degree AV block, some P waves are conducted and some are not. In type 1, there's progressive PR prolongation before the block, whereas in type 2, there is no PR prolongation before the block. Type 1 is usually benign and type 2 requires treatment. Third degree AV block or complete heart block is where none of the P waves are conducted and there is no communication between the atria or the ventricles. I hope that was useful. Thank you very much for watching these videos. Please like and subscribe if you like this channel, and we'll add more videos in the future.